Vamos a comenzar, tengo el agrado de tener el simposio de la ESASO, ¿sí? Vamos a hablar sobre avances en retina. En el panel tenemos al profesor Robert Rejdak, que nos visita de Polonia, el doctor Hudson Nakamura de Brasil, Carlos Agüero de Argentina y Murillo de Bolivia. El doctor Robert Rejdak nos va a hablar sobre manejo de complicaciones severas en retinopatía diabética y además en implantes para maculopatía. El doctor Murillo va a hablar de manejo de glaucoma post-vitrectomía. El doctor Carlos Agüero de manejo del desprendimiento de retina. Y el doctor Hudson Nakamura en casos complejos en cirugía vitreoretinal. Por favor, tenemos un video del ESASO, si podemos pasarlo. Se los agradezco. Thank you, Professor Rejdak. It's an honor to have a ESASO conference in OFTALMOCÓRDOBA. You can have the first talk.
Thank you very much. It's my great honor and pleasure to represent ESASO here in Cordoba and continue our collaboration. We started already this year in Lublin in Poland, starting, I hope, long-lasting collaboration between ESASO and OFTALMOCÓRDOBA. We plan this year, next February, organize a session again in Europe. I am also very happy to be here and to present you my talk. My talk will present difficulties and important aspects of management of severe forms of diabetic retinopathy. So we know that first line of the treatment is anti-VEGF injections according to EURETINA recommendations, together in selected cases with laser, if we speak about DME, and of course pan photocoagulation in a proliferative form. And in case of vitro macular traction or retinal membrane, we consider vitrectomy. We should know that diabetes induces many alterations in the vitreous of diabetic patients. We have aggregation and thickening of fibers. We have stronger adhesion to the surface of the retina, delayed aggregation, almost no or incomplete PVD, and of course higher number of halocytes. So you should always take these changes under consideration when you plan vitrectomy. And there are several types of vitreoretinal adhesions. Type 0, of course, with total PVD, but very rare in diabetic patients. Type 1 with focal attachment to optic disc, relatively easy conditions to perform surgery. Then type 2 with broader attachments. Type 3 with attachment to the disc, arcades, vitreous base, and sometimes due to traction you can have already blood in inferior subhyaloid space with 7% of complication rate during surgery. Type 4, type 5, of course, adhesion is increased to total vitreoretinal attachment. These cases are difficult to be operated. And if we have indications, aim of the vitrectomy is to restore media transparency, to remove tractions, proliferations, perform pan-photocoagulation, of course, treating retinal breaks. And of course, be aware that sometimes PVD is really tricky. In advanced stages, you have really very fibrotic hyaloid attached to the surface of the retina. So you should use certain strategy to perform all parts of the surgery. Indications are ERM, as I mentioned, also tractional macular edema, vitreous hemorrhage, subretinal hemorrhage, and tractional retinal detachment involving or threatening the macula. Crucial is proper diagnostics using ultrasound. We scan through the optic disc to differentiate PVD from detached retina. We can see incomplete PVD, also NVD, also peripheral tractional retinal detachment. Ultrasound is really crucial to plan the treatment. Also important, very important is OCT, especially to detect epiretinal membrane or traction. So we should know that in case of epiretinal membrane, incidence might be between 15 till even 45%, and vitrectomy restores, let's say, the structure and anatomical outcome sometimes is better than functional recovery in the light of literature and publications. If we have epiretinal membrane, of course, nowadays we have chromovitrectomy to stain vitreous body and ILM and of course ERM. And nowadays we have really variety of vital dyes we can use to, let's say, help us to perform vitrectomy safer and more accurate. Here I'm showing you a new dye for vitreous body. This is it was introduced by Bausch and Lomb based on lutein, already on the market, at least in Poland you can buy. It has like orange color and is really nice. You can use it instead of triamcinolol, especially for PVD. Of course, normally I'm using Brilliant Blue dual to remove epiretinal membrane, also to stain ILM. We have shown yesterday, Dr. Nakamura showed us beautiful videos also using staining. Going further on in proliferative form of retinopathy, diabetic retinopathy, we should consider certain steps. Core vitrectomy, then we should perform incision of the hyaloid segmentation and delamination. I am a great fan of bimanual surgery, using chandelier light in both hands, especially in such cases where we have really massive proliferations, also membranes. And we observe it after COVID pandemic, really a lot of patients coming too late to us. Maybe now is better, but especially just after and during pandemic we had such problems. So the bimanual surgery is very helpful. Also, I will show you some new techniques I'm using. And of course, if we have the media are not transparent, it's impossible to perform laser. We have longer than 3-4 weeks vitreous hemorrhage or detached macula, and also long-lasting vitreous hemorrhage. We should indicate vitrectomy immediately. We try to perform laser coagulation before the surgery, but of course we continue during vitrectomy. Also, we use anti-VEGF, but be careful. Normally we inject anti-VEGF 3 days before vitrectomy, and don't wait too long because there is also a risk of tractional retinal detachment. I would like to show you some cases. First is tractional diabetic macular edema, young lady. So I performed before I performed cataract, and this is like 3 weeks later, vitrectomy. So we try to induce PVD using needle, 25 gauge needle to start PVD, being very gently. Then we remove vitreous. We perform a complete vitrectomy to vitreous base. And in this case, we perform ILM peeling also. You see, sometimes it is tricky, and we should look for vitreous using, in this case, triamcinolone. And then we perform ILM peeling. We have ischemia of the macula region, but it is crucial to perform ILM peeling to let's continue laser. This is photocoagulation, and at the end, after some time of let's say good effect, we had to re-inject anti-VEGF. This is right eye. After several anti-VEGF injections, we have let's say a good structural effect of, and also visual acuity 0.7. This lady was a little bit, so to say, compliance was not good, so then she left, and she appeared, so we could examine left eye without anti-VEGF. There were still some edema, But anyhow, this is the strategy. Also, we have quite often oculus ultimus, young patients like here. So we perform vitrectomy with ILM peeling and membrane, this membrane peeling. So quite tricky. You must be careful not to induce also problems, ischemic macula. This is after 4 years post-operatively with 0.3 vision. The situation is stable. Maybe due to lack of time, I will skip this. We are using also small gauges like 27 gauge, but in very special conditions, I try to combine 23 gauge and 27 gauge vitrectomy, 27 gauge for macula, and 23 gauge especially for periphery to really clean vitreous base accurately. In this case, it was severe macula tractional retinal detachment with cataract already. So after cataract removal, we perform we start from 23 gauge system, inducing PVD. Then with needle we dissect hyaloid to let's say to be careful not to induce breaks in the macular region. Then we complete let's say vitrectomy to the periphery, but in the region of macula we try to use so we changed into 27 gauge instruments. On a constellation, you can just exchange vitreous cutter using the same cassette, and we perform dissection of these membranes and the laser, and at the end silicone oil was injected. This is after silicone oil removal, so a really good result, and we follow up this patient. So in general, these are complex cases, difficult surgery, sometimes new strategies like combination of 23, 27 gauge vitrectomy is needed, because this is, for example, one-eyed patient. Of course, take-home message is that not every bleeding is due to diabetes mellitus. There are different also causes, and don't wait too long. Perform vitrectomy. As I mentioned, there are many indications. Also, we use normally anti-VEGF, but be careful. Perform vitrectomy 3 days later, 5 days later, no, not longer. And now I would like to show you just shortly my new project. This is telemedicine used at my department. We have special van. We are going through small villages and towns in the Lublin region with Topcon Maestro 2. The technician is taking photos. Photos are sent to reading center at my department. So these are not ophthalmologists. This is the technician and the nurse. And we decide who should be sent to us, let's say, immediately for anti-VEGF injection. So new approach, more systemic solution to, let's say, treat diabetic patients early. Thank you very much for your attention.
Thank you, Professor. Robert, did you? I make 2 questions for you. Sabemos que la retinopatía diabética, la diabetes es un flagelo que cada vez está afectando a más pacientes en el mundo y va a ser más grave en el futuro. Y bueno, me parece muy importante este nuevo proyecto de tratar de llegar a la población que no puede acceder para uno poder tratar a los pacientes previamente y no esperar a que lleguen con unas retinopatías diabéticas proliferativas, con desprendimiento de retina, que son más difíciles de tratar. En base a esto, o sea, ¿usted está de acuerdo en realizar una vitrectomía temprana en pacientes con retinopatía diabética preproliferativa severa para evitar que lleguen a un estadio más avanzado de la enfermedad y tratarlos con una diabetes, con una retinopatía diabética más severa? O sea, una vitrectomía temprana, sacar hialoides y endopanfotocoagularlo, y uno, como de esa manera, se aseguraría que ya la gravedad de la retinopatía diabética no va a ser mayor.
I am fan of early treatment. So both early diagnostics, and then if there is a bleeding longer than vitreous hemorrhage longer than 3 weeks, we indicate a vitrectomy. If of course we perform complete vitrectomy with PVD, with also vitreous-based shaving. We also, when there is a proliferative stage, we perform endo laser. Not maybe aggressively, but really trying to do like 1,000 spots during the surgery. And of course we follow up our patients. Now I think the project with telemedicine will help us to treat patients early enough.
Ok, y también ¿qué opina de realizar sistemáticamente vi que hace un pelaje de la limitante en todos los pacientes diabéticos? Hay trabajos que algunos están a favor, otros en contra, que dicen que al pelar la limitante puede desestructurar las capas maculares de la retina y puede llegar a ser contraproducente. ¿Qué opina del pelaje sistemático de la limitante?
Okay, so I perform quite often peeling, but I check OCT first. If there are, regions when it is dangerous, cysts, for example, then I try to, and also Dr. Nakamura showed yesterday really clearly, intraoperative OCT can help you to perform not complete peeling and to avoid these regions. From the other hand, ILM peeling stops recurrence of ERM if we have also ERM. So normally I peel and I consider peeling when I have ERM or traction or pathology. If macula is, so to say, in good form, I don't peel. Just, as a systematic approach.
Ok. ¿Alguien del panel quiere hacer algún comentario?
Also, I would like to congratulate you for the cases. And before the diabetic retinopathy gets worse, doing injections is a lot better, of course. And there is a disease that is very much talked about nowadays, is crush syndrome in diabetic retinopathy. So whenever you do some injections, the case, instead of getting better, is getting worse. So that's the time you have to rush, as you said, into 4 or 5 days to the surgery. Otherwise, the case is going to get much worse. So you have to see and not only do injections, and that's the way we do, and seek the patient where the patient is, because otherwise he can get worse, and so you refer him to surgery right away.
Thank you very much for this important comment. This is really, let's say, very crucial to be careful, to control the patient, and to because there is a risk of fibrotic reaction and traction. So really, this is the art how to treat such patients. But then immediately vitrectomy can stop big problem.
Bueno, thank you, profesor. Bueno, vamos a seguir con el programa. El doctor Marcelo Murillo Sasamoto va a hablar de manejo de glaucoma post-vitrectomía.
Bueno, muy buenas tardes. Vamos comentando primero un dato muy importante, que esta es la base de la charla que voy a presentar y la voy a leer. El glaucoma post-vitrectomía constituye el 14% de todos los casos de glaucoma secundario y afecta particularmente al grupo de edad entre 21 y 60 años. Hasta el 35% de los ojos pueden experimentar inicialmente una elevación significativa, mayor a 30 milímetros de mercurio en la presión intraocular. Aunque la presión intraocular se normaliza en la mayoría de estos ojos, del 20 al 25% pueden desarrollar glaucoma crónico. Esa es nuestra situación con las cirugías post-vitrectomía. Y voy a hacer mención y comentarles primero este tipo de casos, que son los casos más agresivos, donde tenemos que colocar una válvula de Ahmed. Es una paciente con diabetes tipo 1, una retinopatía diabética, un desprendimiento de retina traccional bastante agresivo. Le hacemos la cirugía convencional de facovitrectomía, donde una vez hecha la faco podemos ver las estructuras en polo posterior y toda la tracción que presenta en la retina, ¿no? Áreas de hemorragia. Debo hacer notar que previamente, 48 horas antes, se colocó una inyección de antiangiogénico para entrar al quirófano. Y comenzamos a retirar algunas membranas, a tratar de aplicar la retina. Este era el peor ojo, visualmente. Colocamos láser y aceite de silicón. Hacemos el seguimiento, obviamente el seguimiento postoperatorio de esta paciente, donde se mantiene de por vida con hipotensores oculares, pero no requiere un procedimiento ni de mix ni de colocación de dispositivos valvulares. El ojo contralateral era el ojo que presentaba una agudeza visual un poco mejor. Igualmente presentaba un desprendimiento de retina, pero en este caso era un desprendimiento de retina plano, con un regma lateral que producía ese desprendimiento plano. Entonces igual hacemos el procedimiento de facovitrectomía y ahí pueden ver, ¿no?, la porción lateral donde se ve el regma, pero la estructura de la retina en general está claramente conservada, por lo que hacemos una vitrectomía, retiramos hialoides posterior y hacemos el peeling de la membrana limitante. ¿Por qué el peeling? Porque ambos ojos están muy afectados, entonces obviamente las células de Müller están anómalas, y en estos casos sí hay vasos artículos que mencionan que hay que retirar la membrana limitante interna, ¿no?, por esta misma anomalía de las células de Müller. Entonces ahí estamos realizando el peeling de la membrana. Hay vasos exangües igual en esta retina. Si digo que es la mejor por poco, porque igual presentaba mucho daño este ojo. La característica de este ojo fue que no pudimos controlar la presión intraocular, ¿no? Tuvimos complicaciones con el ángulo. En el postoperatorio, si bien colocamos aceite de silicón, nos fue bastante complicado el manejo y tuvimos que colocarle una válvula de Ahmed FP7 para controlar, ¿no? Si ven, la cámara está bastante estrecha, ¿no?, como un cierre angular. Tuvimos que hacer una iridectomía para estabilizar el cuadro y posteriormente, a los 15 días, porque con hipotensores en un inicio se estaba manejando adecuadamente, pero posteriormente tuvimos que colocar un dispositivo valvular para controlar la presión intraocular. Esos son los casos severos, pero lo que he leído hace un momento hago mención sobre estos casos, una simple vitrectomía, una simple hemorragia vítrea, que nos puede generar también estos picos hipertensivos y cómo deben ser manejados. Actualmente la plataforma con la que trabajo hace ya más de 14 años es OERTLY. En estos momentos, desde el 2015, utilizamos el OS4 y la característica de este OS4 tiene una variante de mix que se llama HFDS, que es High Frequency Deep Sclerotomy, y es la que normalmente en las cirugías de retina o cuando coloco alguna válvula, obviamente con un ángulo abierto, la hago previamente, porque este tipo de técnicas nos baja entre 8 y 9 puntos de presión, y de esa forma en el cabo de 6 meses también nos crea cierto grado de estabilidad respecto a la presión intraocular. Gran parte de nuestros pacientes utilizamos gotas hipotensoras, es por eso que ese tipo de procedimientos nos ayuda a apaciguar estos picos hipertensivos y tener un mejor control de la presión. Continúo. También tenemos pacientes altos miopes, que son los pacientes que tienen más recurrencia y más chance a hacer glaucoma. Este paciente era un alto miope, creo que era de 20, hicimos una cirugía igual de facovitrectomía, presentamos desprendimiento de retina, donde una vez aplicada y pegada a la retina y haciendo todo el procedimiento, tuvimos que hacerle seguimiento, manejo con hipotensores, y al cabo igual de unos 15-20 días presentó picos que no se podían controlar con hipotensores, así que procedimos igual a colocar una válvula de Ahmed. En estos casos, altos miopes son sujetos a este tipo de cambios, hay que estar controlando bastante a estos pacientes, ¿no? Cómo el cuerpo, en realidad cómo el cuerpo ciliar puede alterarse, cambiar la dirección para producir este tipo de glaucomas que pueden llegar a ser crónicos, como habíamos mencionado anteriormente. A este paciente colocamos una banda, un scleral buckle, para poder asegurarnos que la retina está bastante estable, y posteriormente nos hizo los picos hipertensivos y tuvimos que colocarle un dispositivo valvular. Ese es otro caso en este tipo de pacientes. Y ahí estamos colocando la válvula FP7. Entonces, la característica del HFDS es un procedimiento AVE interno, y tenemos muchos en el mercado, pero este resulta ser el más barato de todos, porque yo le hago el procedimiento a mi paciente y no le estoy cobrando extra por hacerle este procedimiento AVE interno, sino que es un complemento a la cirugía de retina, ¿no? Y la característica de este procedimiento es que tenemos un tip, es una sonda, que es el AV tip, que es una sonda diatérmica de alta frecuencia, donde genera temperaturas de 130 grados para poder quemar toda la parte del trabéculo en dirección al canal de Sallam, para tener mayor espacio y que la presión y que el humor acuoso igual comience a disminuir o pasar por esa zona de una forma más cómoda y más fácil, ¿no? 500 kHz genera una temperatura de aproximadamente 130 grados centígrados en la punta de la sonda. La característica igual es que al calentar el tejido no genera la aparición de fibroblastos, entonces es un tejido y es un calentamiento bastante controlado y limitado. Los beneficios buenos de hacer este tipo de procedimientos, este tipo de mix, es que posteriormente podemos realizar, si es que no funciona, otro tipo de procedimientos como la colocación de una válvula, trabeculectomías, evita el estímulo de tejidos epiesclerales, como había comentado, y hay un bajo grado de complicaciones en comparación con otros procedimientos. La característica es justamente crear a través, en dirección del canal de Sallam, este tipo de aperturas para el mayor flujo y el mejor flujo del humor acuoso. El procedimiento es bastante sencillo, yo creo que aquí Ortli se maneja bastante. Esta es una paciente, solo para comentar, que tenía un síndrome de pseudoesfoliación, pero todavía el trabéculo era funcional en un 40-50%. Entonces, incluso en este tipo de casos, podemos realizar el HFDS, donde otra vez, guiados por gonioscopía, vemos cómo está y en qué disposición está el trabéculo, o en qué situación está el trabéculo, para poder, posteriormente, una vez retirada la catarata, hacer las quemaduras correspondientes. Primero son los 180 grados inferiores, y si queremos bajar más la presión, podemos entrar al quirófano y hacer los 180 grados superiores para bajar un poco más la presión. Normalmente, en nuestra experiencia y en los artículos que hemos realizado con este tipo de técnicas, son 8 o 9 puntos aproximadamente que baja este tipo de técnicas y se mantienen estables en el transcurso de los siguientes 6 meses. Es una técnica bastante sencilla, bastante noble y que en los casos de cirugía vitreoretinal la estoy implementando para poder regularizar adecuadamente la presión intraocular. Entonces, ahí estamos con él viendo la malla trabecular para poder realizar las quemaduras. Como ustedes ven, es un procedimiento bastante sencillo. A veces puede haber un pequeño bleeding, un pequeño sangrado, pero es muy leve. Hacemos los 180 y de esa forma vamos haciendo el seguimiento y disminuimos también las gotas que necesitaría el paciente si es que tiene estos picos hipertensivos. En conclusión, los puntos importantes: el HFDS produce un flujo a través de la malla trabecular por el canal de Sallam hacia la esclera, ¿no? Evita la formación y movimiento de fibroblastos hacia el área de la esclerotomía. La presión intraocular continúa disminuyendo durante los primeros 6 meses para luego estabilizarse y puede combinarse con cirugías de catarata o ser coadyuvante a controlar la presión postcirugía de retina, así como permite también realizar otros procedimientos antiglaucomatosos posteriores si fueran necesarios. Yo creo que es una muy buena opción y tenemos que comenzar a utilizar también MIGS en estos casos de retina, ya que la incidencia de tener un glaucoma crónico es bastante elevada. Muchas gracias.
Thank you very much, Marcelo, showing us mix in such cases. Indeed, Earthly now provided us a very good tool, and also our other companies I could see at ECRS also memes of Bausch and Lomb, so probably we should test also in the future such solutions. Anyhow, this approach gives us, let's say, step-by-step possibilities. If it does not function, then we consider Ahmed valve, yes, or different techniques. So thank you very much. Other?
Marcelo, congratulations. Muy buenas cirurgias. Usted ha utilizado aceite de silicone no primeiro caso. Os outros usted não utilizou. Por quê? Porque isso pode prejudicar por causa da válvula?
No, para nada, porque la válvula igual la colocamos a nivel de la cámara anterior, no por detrás ni nada de eso, ¿no? Pero también usé en el segundo caso aceite de silicón. O sea, en los 2 ojos de la paciente diabética, los 2 estaban con aceite de silicón. Solo que en el ojo izquierdo la válvula estaba en cámara anterior y sí, se pudo manejar, pero en ningún momento no usé silicón, usé los 2 ojos.
Sí, y siempre que posible usted retira la membrana limitante interna, eso es importante, ¿no?
Si veo que hay un daño agresivo, como estos casos de retinopatía diabética, donde son varios años de enfermedad, o vemos que hay mucho daño a nivel de polo posterior, bastante agresivo, sí. Pero en estadios iniciales, cuando quiero hacer un tratamiento prematuro y veo que la limitante está tranquila, no la toco. No la toco. Okay.
Muy bien, vamos a continuar con...
Thank you very much.
Thank you. Con mi presentación. Mi presentación es acerca del manejo del desprendimiento de retina y la idea es un poco mostrarles cómo pensamos los diferentes casos, ya que en desprendimiento de retina lo que pasa habitualmente es que cada uno podría abordar la cirugía de diferentes maneras. En nuestro caso, somos muy propensos a usar el backlink escleral. Esta es la alternativa de indentar un poco la pared ocular para relajar el vitrio, la base vítrea. Podemos tener la alternativa de backlink circunferenciales o segmentados. Cuando usamos los circunferenciales, indudablemente lo podemos hacer en desprendimiento de retina que son para pacientes fáquicos jóvenes, para cuando tenemos roturas inferiores o para cuando tenemos una diálisis retiniana sin desprendimiento del vitrio, o también muchas veces cuando tenemos desprendimiento de retina que son reumatógenos, retinogénicos, pero con algunos agujeritos tróficos que no podemos percatarnos. Y en el algoritmo, la inclinación está más que todo para pacientes de 50 años o menos, la idea es ver que este daño reumatógeno sea retinogénico, en donde indudablemente elegiríamos backlink en general. Y si en nuestros pacientes tenemos un componente vitreogénico, dependiendo del grado de ese comportamiento, podemos o continuar con el backlink o combinar ese backlink una vitrectomía. Ustedes pueden ver acá que la colocación de la banda siempre se hace en los 4 cuadrantes y lo que hacemos es pasar siempre a la izquierda de la banda, viniendo con la sutura, y a la derecha yéndonos o alejándonos de nosotros. De esta manera nos queda distal el anudado y nos deja ser precisos con la indentación de la banda que decidamos para nuestro caso. Y si luego nos inclinamos a una indentación segmental, esto puede ser poniéndolo de manera radial o horizontal, dependiendo del comportamiento de ese desgarro que tengamos. Ustedes lo pueden ver en las imágenes abajo, que se está trabajando en un solo cuadrante. Y miren ahora el caso de esta paciente. Llega a la consulta con una rotura temporal superior, se le hace láser de su ojo derecho, eso se resuelve sin problema, pero la consulta había estado por el ojo izquierdo, que tiene el desprendimiento hacia nasal. En ella decidimos poner un segmentado en esos 2 cuadrantes, se puso gas y la paciente, al ser una paciente pseudofáquica, no tiene alteraciones de su ametropía después de la cirugía. En este caso tenemos otra rotura anasal superior y decidimos lo mismo, pero ahora trabajando solamente en el cuadrante superior y nasal. Se pone el gas y la indentación termina siendo muy buena. En este otro caso se busca lo mismo en esta rotura, solo que la paciente demora en realizar la cirugía por cuestiones personales, la bulla se vuelve aún mayor, pero no cambiamos la planificación, ponemos una buena indentación y tenemos el resultado esperado, pero acá el gas va bien hacia abajo, hacia el cuadrante inferior para evitar problemas. Y en el caso de las diálisis, nos complementamos un poco con la lámpara de hendidura, en donde lo que nos permite es ver bien el sector en donde tenemos que indentar. Acá hicimos láser transescleral, que pueden ver las quemaduras, y se pone el segmentario en los 2 cuadrantes inferiores para ir chequeando luego al final del procedimiento que se esté indentando, como se ven en las imágenes del California. Se deja gas y cuadro resuelto. Cuando empezamos a pensar un poco en la alternativa de hacer vitrectomía, tenemos que ayudarnos con los microscopios de última generación que nos permiten ver mejores imágenes. La utilización de los pedales es importante para el endoláser o el láser externo, y el pedal dual es sumamente útil para una vitrectomía controlada. Ahí el algoritmo de tratamiento está inclinado más para desprendimiento de retina regmatógenos de pacientes mayores de 50 años, ya sean fáquicos o pseudofáquicos. Y en este caso, nosotros si vemos una rotura que es retinogénica, seguimos apostando al backlink escleral, pero si hay un componente vítreo, directamente nos inclinamos a la vitrectomía. Vitrectomía, como les decía, con los nuevos microscopios que nos permiten jugar con los filtros. Si utilizo el filtro amarillo, me voy a estar inclinando a mejores imágenes, como ven, del polo posterior, y si voy con el filtro verde, mejor información de la retina en la periferia. Es una herramienta útil, y una técnica útil, indudablemente para nosotros, es la retinectomía radial. En la retinectomía radial, como ven en el video, lo que busco hacer es directamente prolongar el desgarro de la rotura bien hacia la parte periférica. De esta manera estoy relajando toda la base vítrea y me permite hacer láser, ya que todo el líquido que estaba subretiniano se va liberando. Entonces, con la retina aplicada puedo sellar todos los sectores de mi desgarro para hacer al final un intercambio fluido-aire. Entonces, si ustedes ven, la retinectomía hace como la hacía la banda de manera externa, internamente me relaja la retina, me segmenta la base vítrea y me deja para último momento el intercambio fluido-aire. Acá vamos a ver otro caso, que hago también la retinectomía radial, comienzo con tijera. En este paciente habíamos hecho un primer procedimiento y después la tracción me empezó a hacer un desprendimiento plano. Miren cómo con el perfluoro seco la retina y una vez que está aplicada por la retinectomía, termino por sellar esa rotura, ese desgarro que hice de la retinectomía radial con la retina ya completamente aplicada. Una herramienta muy útil también cuando hacemos vitrectomía es ayudarnos por el indentador escleral que es iluminado. Entonces, tanto con la chandelier como este indentador, miren qué fácil que se ve toda la base vítrea para hacer un buen shaving, tanto del lado nasal como temporal de este paciente. Y miren la utilidad en este caso que pueden ver de un desprendimiento temporal superior, en donde los microscopios te dejan ver bastante de la periferia. Ustedes pueden ver la rotura y cómo estoy haciendo láser, pero miren ahora que me empiezo a ayudar con la indentación, cómo se ve mucho mejor la base vítrea, y yo me puedo asegurar después de terminar de sacar todo el vitrio que pueda estar traccionando en ese sector. Algo más para utilizar es la diatermia. Lo utilizamos mucho en desprendimientos de la retina traccional. Eso contrae un poco la malla fibrosa y me da planos para después sacar la tracción con una pinza para en última instancia hacer con vitrectomía la extracción de la misma malla fibrosa. Entonces, a manera de resumen, si tengo desprendimiento de retina reumatógeno en menores de 50 años y son retinogénicos, seguro backlin escleral. Si empiezo a encontrar algún componente vítreo de un poco de pigmento o un desprendimiento del vitrio del polo posterior, lo voy a tener que combinar con vitrectomía, pero haría backlin también. Y en el caso de que ese paciente es mayor de 50 años, fáquico o pseudofáquico, solamente que me asegure que tengo un componente retinogénico, haría backlin, pero si no, haría solamente vitrectomía. Vitrectomía que lo respaldaría con un buen microscopio para ver bien la periferia, indentando con el indentador que le mostraba del Viper, y si es posible que esa rotura sea periférica, intentaría llegar bien con una retinectomía para asegurarme la aplicación de la retina. Muchas gracias.
Yeah, very cool surgeries. I like a lot the way you look at the retinal periphery and you do your trimming and get the vitreous base very well visualized. And one important thing is that you mentioned that many people go to vitrectomies like that for diabetic retinopathy proliferative without using the endocautery. So it's very dangerous. Otherwise, you could get hemorrhage and you don't know what to do. Have to keep doing and pressure, raising the pressure and doing air fluid exchange. And then if you got a lens, you get the lens opacity. So the best way to deal with that is doing the endocautery. You did it very well. Congratulations.
Exacto, exacto. Sabes que justamente para la retinopatía diabética, cuando tenemos hemorragia vítreas, se vuelve una maniobra muy útil sacar toda la hemorragia para practicar la técnica en cada uno de los cuadrantes, porque la hemorragia vítrea te deja justamente ver bien la base vítrea y liberar todo eso que tenemos ahí, y cuando tenemos luego un desprendimiento de retina con una rotura, ya es más práctica la maniobra.
Okay, and you do your buckles, in what percentage you do buckles? Because you do buckles very well. You know, people are not very keen at doing buckles anymore, and you had great indentations with the buckles, and that's good. You do more of the silicone bands or the other way around?
Siempre silicone band, sí. Pero somos muy propensos a usar bandas o los segmentarios también, que son de esponja, de 5 milímetros.
Ya no sé si hablar en inglés, but there's a piece that he mentioned called Viper. Viper is an indentation artifact that this Viper, the earthly platform, has, and one particular position that I usually do is turn off the endoluminator and only work with the Viper. The light of the Viper generates more, for the periphery, a more accurate view, right? Y es lo que me encanta del Viper también.
Exacto, exacto. Tenés la iluminación interna del chandelier y la externa del Viper sumada a la indentación que te está generando.
Exacto.
Entonces, indudablemente que te deja ver bien la base vítrea y te evita lastimar la retina.
Sí. Y a veces apago todo y solo me quedo con la luz del Viper y comienzo a poner láser. En ese momento no me va a pintar, pero cuando enciendo otra vez, ya está toda esa parte. Cuando son periferias extremas que te cuesta llegar con el láser, ¿no? Entonces es un excelente aparato.
Exacto. Muchas gracias.
So on behalf of Dr. Mario Toro, I will present his talk. Just unfortunately, he had to join another meeting. I was also invited, but I am, so to say, older and his boss, so I told, you know, I I dream about Argentina, so I go to Argentina and you must go to Berlin. So now he is in Berlin, but I must do his job. So I would like to share with you first results of telescopic intraocular implants in patients with AMD. So we know that this is a really growing problem due to both dry and wet AMD, and it's a really social emergency because of irreversible central blindness in these patients. These patients are in a big group, they are healthy, but they are losing central vision due to scar, due to atrophy in macular region. And of course, up to now, there were no options how to help them. Since many years, I implanted chariot lens to these patients, but somehow when atrophy progresses, the effect was not enough. So we have also now Apellis, also we know that Astellas company also is coming with intravitreal injections against geographic atrophy, but in a late stage, we already have some experiences with Samsara lens, and not only low vision eyes, but also at the moment we can help our patients implanting new IOLs. So there is a new hope. This lens is created by Samsara company. The name is Sing IMT. It is Galilean telescope and giving magnification 2.7 times. And the system is really special, made of glass and silicone. And you can see here there are indications like irreversible late stage of AMD. Anterior chamber should be deeper than 2.5 millimeters, and also this lens can be implanted during standard cataract surgery. If we want to, let's say, examine the patient and indicate the surgery, we should use special simulator to show that there is an improvement. And you see, normally after seeing implantation, we have magnification of the central, let's say, object, but fellow eye should provide peripheral vision to give orientation for the patient. The system looks like this. This is a preloaded system. We have a cartridge, injector, and this is the way how we implant the IOL. So it is it jumps into the capsular bag. This is a special model to show you how it comes to capsular bag. And we already, let's say, we can already read the paper of Dr. Mario Toro and his colleagues. The Naples group implanted, I think, the biggest number of these lenses, and they showed that in 24 cases there was already improvement in 58% of eyes. Authors observed that the patients gained 3 or more lines. Also, it was quite, let's say, comparable with previous model. within 3 months, endothelial cell counts decreased in around 10%. And also they observed depth of anterior chamber, which was comparable with older model of the lens. And there were some, let's say, complications, but not severe, so to say. So altogether, the system is promising. I had a possibility to implant this lens also in Lublin. This is my department. Of course, we prepared the team to, let's say, implant this lens. We used special simulator to examine the patient. And this is the surgery, so standard cataract surgery. We remove cataract. And let's say the problem is that during implantation of this sync IMT IOL, you should really enter the anterior chamber with injector, which is quite big, and introduce this IOL and haptics into the capsular bag. Of course, the incision is 7.5 millimeters, so we suture, we put stitches to close the wound, and altogether, in our patient, this is one case already, but we plan 10 implantations this year. So in this case, we had really improvement from 3 letters till 12 letters. So at the DRS from 4 meters, the DRS from 1 meter was from 13 letters, the improvement till 28 letters, and the eye was, let's say, looked good already after the surgery. Now, after 3 months from surgery, the patient really is happy. She can read. She can recognize faces of, let's say, family members. So these results are encouraging. Already in Europe, in US, there are many centers implanting the lens. So I think the project will develop. It is really effective treatment, safe, and of course we need more patients and longer follow-up. Thank you very much for your attention. If there are any questions, I would be happy to answer.
Yeah, great case, and this IOL is really fancy, and what do you think is missing for, this lens to get to other countries?
So at the moment, still the price is quite high, 25,000 euro is the price. So at this stage, the company is observing, so to say, results, safety. So we have a series of IOLs for free as a research project. But I know that, for example, in Germany, this kind of treatment is already reimbursed by a public system.
Okay.
So do you think there's some future with this lens? Because it's too big, and sometimes that's the problem, because it's too big, and the decision is really...
So I know that in Italy there are several centers, and I mean, patients are happy. There is a good effect, and this is the only way to give them vision with scar or atrophy. It is much better than magnifying lens in the shop, in the bank. So I'm optimistic.
Okay, thank you.
Thank you very much.
Thank you, and have the honor to present here for the first time to ESASO, this great scientific meeting, and I will show you some cases in vitreoretinal surgery, and this is called challenging vitreoretinal surgery cases. We are used to the cases that we do oftenly. I've got no conflicts of interests, but these cases we have to deal with them, and we learn with time and experience. And we are attached to the iBank Foundation in Brazil, and I'm founder of Retinosome. Happy to present Retinosome yesterday, and this was our meeting with Retinosome last month in Belo Horizonte, Brazil. And we have also studies with the French Academy of Surgery. So this was yesterday. So let me start it right off. Our case, could be called a surprise case. Interesting one. We showed this last year in the EURETINA in Hamburg. This is the iBank Foundation. So how to deal with the vitrectomy doing this, oh sorry, I think I pressed 2 times. A second. This is a tough macular pucker. So how to deal with some macular puckers that appear to us, and how to take care of these issues. You've got this very taut hyaloid and very distorting macular pucker. You see the vessels all over like that. Very bad case. And so what could we do? We got to do something. We cannot only do the irregular things. So after vitrectomy, this is the first stain. We removed the hyaloid. This is probably the most beautiful image I have ever seen in the art of ophthalmology. So I usually call Retinosome because it's awesome for images as well. So we get to see some different things. And with a very fancy 25 gauge forceps, we remove the epiretinal tissue very carefully. This is the forceps I've just shown you, Rejdak, and you gotta be very slow, otherwise you could tear the retina. And by now, I'm peeling the epiretinal tissue with a good stain of brilliant blue. Still, the ILM was not stained, but in the contrast that the brilliant blue gave me, it also stained the epiretinal membrane. Now the second injection for staining the internal limiting membrane with brilliant blue, you're gonna see that you have more in the bluish tint at the ILM that remained behind the epiretinal tissue. So you could grab this internal limiting membrane very slowly, and of course, the work wouldn't be finished if you didn't remove the ILM behind, because there were so much contractions below this epiretinal tissue that you had to get away with that as soon as possible. And now using the perfluorocarbon just to make it more stable. Sometimes I use the perfluorocarbon, and sometimes perfluorocarbon helps you in dissecting the ILM more easily, and sometimes it presses on the macular area, making the outcome a little better. Now doing this air fluid exchange. Another one, because the first one was made to better stain the internal limiting membrane, so I usually do a complete AFX for that purpose, and that's the case. It got a lot better. You don't see that pucker anymore. And so it was really, really attached. Of course, the chronicity of the pucker left the retina unstable in terms of width, and also it's the more distorted one anyways, but we did whatever could be done for a case that would probably have no hope for surgery. So we always have to look after the best things for the patient. And this case, we did it well. We are still following the patient. It's getting better. And some of these patients, they are referred to the clinician also to follow up and keep things stable. So it got better, so no more tractions. And that's about it. And this is the surprise case I was going to show you. Sometimes everything seems to be very well. So to start with this diabetic retinopathy case, many wouldn't do anything because there is a fibrosis in the macular area. This video was also displayed in itube.net. And when I started the case, I thought nothing could be done. As you see here, whenever you try pulling the epiretinal tissue, everything comes up. So what to do? Should I give it up? So you could rather choose bimanual technique, but by feeling and being sensitive enough to feel how the membrane attaches to the retina, you go very slow. And you see now that I got this cleavage plane. By getting this cleavage plane, it was easier to separate the epiretinal membrane and fibrovascular tissue from the retina. And take a look, pay attention on what happened. Half of the forceps fell down. So now I have to get away with that because now I have two cases in one. I have one very proliferative diabetic retinopathy case, and I have intraocular foreign body caused by me because the forceps just broke away and have to remove it anyways. So stay calm, and now it's time to relax, and let's do whatever has to be done. And the foreign body was removed. And of course, we got to have the second plane or plane B, and I had another ILM forceps handy. So just to show how big was that, I decided to do a peripheral retinectomy where you see retinotomy, where you see the PVR, to relieve the retina traction very peripherally. And now you see the macula is a lot better. We peeled it off, and we have just a nasal remains of the epiretinal tissue, not causing any traction. So doing laser now with under perfluorocarbon liquid, you see you've got a new macula. You did not have this macula before removing the epiretinal tissue. Now doing a perfluorocoagulation up to the periphery and supporting now the peripheral retinotomy that was performed. You see the pupil is small and the patient got phakic and all the time. And that's the case. This was a real surprise that I wanted to share with you. Thank you very much.
Tengo una pregunta. ¿Notaste que en el primer caso del Packer macular se veía una línea hiperautofluorescente del desplazamiento de la retina que después mejoró la morfología de la mácula, pero no logró relajarse más o no se generó un desplazamiento de la retina porque no volvió a cubrirse? ¿Se mantuvo la línea hiperautofluorescente? ¿Lo notaste de los vasos?
Sim, se mantuve a linha autofluorescente, pero que não havia mais tração. Então, eu penso que agora, porque aquele pucker estava muito tracionado na região macular, todo estava elevado.
Exato.
Então, não há mais tração. E a autofluorescência se mostrou muito melhor, porque ao início da autofluorescência, você poderia ver tudo muito arraigado, muito contraído.
Exacto.
E depois, isto, claro que não melhora tanto o prognóstico, porque a membrana do pucker estava já há muito tempo, mas sim, mais trações, o paciente está muito melhor hoje.
Exacto. Muchas gracias.
Congratulations. Really great surgery. What is your strategy in staining? So you showed us that you even stain several times structures. Yes, this is your technique.
Yeah, my strategy in staining, I like to stain well. And some cases, as I was telling yesterday during retinosome, I don't like staining vitreous because I like to do vitrectomy seeing the vitreous. So I start vitrectomy in the core and do core vitrectomy. And after core vitrectomy, I go towards the periphery. And if I get the hyaloid, and then I know whether the vitreous is there, I keep following the vitreous, and of course taking a very good care to avoid the lens if there is a lens there. So I go peripheral by moving the eye as well. But my strategy is to, after doing the core vitrectomy, and then I put the macular lens. So I see everything in the vitreous, I catch, I grab the hyaloid, I grab any epiretinal tissue because I see it. And of course to go after the macula, and get an epiretinal membrane, I do the first stain. The first stain will stain everything but the ILM, because the epiretinal tissue is covering the ILM, but it could stain, as it stained in those cases, it stained the edges of the epiretinal membrane, and then you remove it and do the second stain. After doing the second stain, and that's about it, and then you have the ILM staining, and then you just grab it out.
Mm-hmm. Thank you very much. And the second question, what is your approach to phaco-vitrectomy, especially in such complicated cases with PVR? Do you perform a combined procedure, or what is the approach?
Yeah, my approach for phaco-vitrectomy is I was telling you yesterday, discussing some cases, and we've got just these cataracts like that, not much. It's 1 out of 4, 25%, and it's easy to do without removing the cataract, especially in diabetic patients. And I prefer to keep the lens to cause less complications also in the anterior segment, and not to move everything out. So I prefer not doing the cataract, but if the case asks you to do that, and then I would do the phaco-vitrectomy. It's easy to do that, you do, and you complete with the vitrectomy right away. So I don't think that's a problem. I like doing phaco-vitrectomies, except that most of the cases I prefer not to, but in case I have to, I will.
Okay, thank you very much. Are there any questions? More?
More than 45 years old, I prefer to do vitrectomy. No, I prefer to avoid some complications in the future. And if I put some tamponade, for example, silicone or gas, I know that in the future probably the patient would have cataract, so I prefer to do a phaco-vitrectomy.
So we have another presentation.
No?
Yeah, sure. So now, last but not least on our list here, I want to show you a case from Dr. Ahmed Sallam that he was not able to come due to some family matters. And so I have this case handy here, and he asked me so much that we could present his case. Just a second, let me just, yeah, that's it. So.
It's Sallam here from Arkansas. I do apologize for not being able to make it in person due to strong family reasons. I hope you're enjoying a great meeting, and I'm delighted to try to be with you at least virtual. My talk is focused on the use of scaled buccal surgery for primary retinal detachment. I don't have any financial disclosure. So as we all know, scaled buccal, whether segmental or circumferential, works by closing the break from outside. We know that the primary success rate of pneumatic retinopexy is less than buccals and vitrectomy. How do buccals compare to vitrectomy? For a study here from 5 centers in the US, a large study, they found very comparable results. Even buccals had better vision after controlling for cataract. The second study The second study is from national database from the UK that I did with colleagues, and we found again very similar comparable rates between primary scleral buckle and primary vitrectomy for retinal detachment. So what are the indications of primary scleral buckle in my practice? I think the first set of indication is so important because this is an indication where you're disadvantaging the patients, in my view, if you do primary vitrectomy. There are patients, usually young patients with no PVD detachment, and the retinal detachment is caused either by an atrophic hole or, as in the second picture, due to retinal dialysis. A localized detachment, even in the presence of PVD, especially inferior, can also be a good indication of a segmental buckle. Why scleral buckle in patients with retinal detachment in the absence of posterior vitreous detachment? And the reason is shown in this video. These cases, the hyaloid is so adherent, and it's a very difficult surgery to induce PVD and sort out the retinal detachment. In many cases, these could be chronic, where you may need to use a long-acting tamponade up to silicone oil, and there's really no reason for this. More important, in myopic patients, they may have lattice retinal degeneration in the mid-periphery or periphery, and we know that pulling on these areas can induce many breaks, and you may even not be able to separate the hyaloid of the breaks. There are different ways of classifying the types of buckles, but my preference is segmental non-drainage buckle, radial or circumferential. If it's a very chronic detachment or if the tear doesn't settle well, then I would need to drain. Indeed, when retinal tears are posterior, they're difficult to buckle, but as long as the tears are anterior to the equator, even in this case a bit posterior, you still can buckle it nicely there. The green arrow points to the area of drainage. I'd like to share with you a few cases. The first case is a patient who had an asymptomatic retinal hole that was treated with laser prophylactically elsewhere, and then the patient developed a retinal detachment from the edge of the laser. I like to use the microscope, and I'll show you my technique in a minute how I use the endo-illumination. We hooked and slung the superior rectus and the lateral rectus. Now I put one trocar opposite to the detachment just for illumination when it's needed. Now sutures are placed using 509 sutures. Segmental buckle is placed under the suture and under the superior rectus. A paracentesis is performed to soften the eye because drainage was not intended. And the buckle is tied down with the sutures. Here is the view from inside. Very nice buckling of the area of interest, and although there's fluid there posteriorly, it will absorb because the area of interest is buckled nicely. Now the buckle is trimmed and the sclerotomy and the conjunctiva are sutured close. This is the first day after the surgery with the OCT and attached macula. And this is day 8, and we've added laser to the edge of the previous laser where the break would be. Now there's a second case which has atrophic hole, so we decided to place a radial buckle. We use a very similar technique with a trocar placed opposite to the area of interest and the illumination here just to localize the tear. Now the radial sutures are placed. Again, we're using a 5mm buckle, so these are 7.5mm apart, straddling the tear, and cryopexy is performed, followed by paracentesis, then placing the scleral buckle and tying the sutures down. Now the buckle is trimmed and the sutures are placed for the sclerotomy and the conjunctiva. The postoperative appearance after the buckle. And this is the last case here, a 40-year-old patient with traumatic retinal dialysis, supranasal, MAC-off detachment, and macular hole. Again, because of the age of the patient and the type of tear, we treated him with just a segmental buckle. As you can see here, this is the localization, followed by cryopexy. And a segmental circumferential 5mm buckle is placed with the sutures placed 7.5mm apart. Paracentesis is performed before tying down the buccal sutures. This is the view from inside, whereas the peripheral part of the retinal lines is supported by the buccal, so no drainage was needed. This is the appearance at day 1, with the hole starting to close. And this is the appearance at day 7, with the retina flat and the hole closed. I appreciate your time. I'm sorry that I'm not here in person. And thank you so much for your attention. I'd love to hear from you by email. Thank you.
Yeah, it's interesting. Ahmed is watching live now, and thanks, Ahmed, for the case. And it's very interesting. I was discussing here with Marcelo that we are doing less and less square buckles, and the way he does segmental buckles is very fancy. So it doesn't take long, and the difference, when you do a regular buckle, you drain, and then you tighten the other way around, because he has to tighten, but he cannot forget to do the anterior chamber of paracentesis, otherwise the pressure is going to go very high. So what do you think about it? And are you using more or less square buckles?
Actually, I usually my technique is with phaco-vitrectopexy sometimes. I divide it in 2. I perform first the vitrectomy, and 1 week later the other procedure, or other way around. I believe this you create less inflammation with those procedures, because if you do one entire procedure that's phaco-vitrectopexy, it's going to be too much inflammation for the eye. So just 1 week using methotrexate to avoid PVR. And it's, I think it's a good option, but I do a lot of scleral buckle. Sponge, not that much, but Charlie demonstrated us that it's a good option to segment some procedures, with segments of sponge.
Yeah, he's talking about that, and I know I have to ask him now this, because he is using a lot of methotrexate for PVR. And so could you tell the audience and people about your dosing on methotrexate, how you use that?
1,200 for intraoperative, using with the BSS. And then every week or every 15 days, I use 400 micrograms for at least 6 months with patients, with PVR patients, complex cases with that, but not less than 6 months.
All right.
I saw yesterday that you presented pediatric case and vitrectomy combined with cerclage. What are indications? When do you perform this kind of technique? Only in children, but do you consider more cases, let's say?
I mean, square buckle in pediatric patients?
I asked you.
Traumatic patients, some diabetic patients also. So methotrexate can help us with many retina pathologies. But also trauma is very good with trauma. Yes. 10-year-old, yes. A scleral buckle, yes. And methotrexate also. The three, and the Tetris technique, right? So yes, I usually do that in those complex cases of retinal detachment, and I prefer to put some scleral buckle in kids.
Okay, thank you very much. I think it was a really interesting session covering many aspects of VR surgery. So I hope to continue the collaboration with RETINA group. Also, ESASO I will discuss with my colleagues in Lugano. And we are grateful and honored for invitation to OFTALMOCORDOBA. Thank you very much.
Thank you. Gracias.